Thank you all for coming to this program this morning. And Quality Improvement Project is our official first Task 1A project, and it's improving AV fistula rates at facilities with AVF and use rates below 67 points. Some background information on this project. You know, Network 16 leads the nation in AVF and use rates, and we actually have exceeded the CMS 66% goal that was set as a national goal. We thought perhaps we would be able to just maintain that goal and work on different projects, but we were told by CMS that we would have to get a 1 percentage point improvement, which is the minimum allowed under the formula that they use for our quality improvement projects. And since in March of 2011 we were at 66.3%, our new goal for March 2012 is 67.3%. And in March of 2011, that's when we do our final data for the prior year, we had 56% of our dialysis facilities had rates that were below our new target of 67.3. And then we looked again in June, and we found that there were 81 that were still below the new target. So, where did these projects come from that we do with you and your facilities? Well, we have some requirements under the contract, and we are contracted with CMS, the Centers for Medicare and Medicaid Services, to provide quality oversight for the Medicare beneficiaries that are in your units. Well, we actually oversee the quality of everybody's care, but as far as CMS goes, it's the Medicare beneficiaries. And per our contract, we are required to focus on 4 different areas. The first one being vascular access, that's our Task 1A, which is this project. And then the old clinical performance measures, those yellow and blue forms that you had to fill out on an annual basis. Well, now that's been, we've substituted the eLab project, and that's just a temporary project that we do until Crown Web comes on board. And when Crown Web comes on board, then you'll be reporting those 3 months worth of data right into your individual patients, and we'll get that data that way. And then we have a network level project that we're doing, and then we have a facility specific project that we have to work on. So we're required by the contract to look at those 4 different areas. And this particular project, we have run over the last couple of years a project that's very similar to this one. It was a declining rate. So if you had reached the goal and then you slid backwards, we had done a project like that for the last couple of years, and it was quite successful. And so we decided that we would just include everyone that was below what our new goal is for this year into this project. Now, how did we identify the facilities? Well, we said it was all facilities with AVF and use rates below 67.3 that had at least 7 patients. So if you're a really, really tight clinic, then you were excused from this project. And then we also looked at your other clinical data, and if you belonged in another one of our projects and we thought you would benefit from a different project than this one, then we took you out of this project. We found several years ago that if we had you in more than one project, we just didn't get outcomes from any of the projects that you were in. So we don't subject you to any more than one project in a project period. So out of those 80 facilities, we have 62 facilities that are participating in this project, and that involves 3,930 patients. 2,431 of them have AV fistulas, and 1,501 do not. And the aggregate, so that is the total, we look at the total numbers. We're not looking at individual patient numbers, but we're looking at your facility total numbers of your AVF and use rates. And currently, the 62 facilities that are in this group have an AVF and use rate of 62%. So you can see we're 5.3 percentage points below the target. Now, we just want to review what the network goals are. And I just noticed that we've got the old goals up here on the sheet. But our percent prevalent patients with AV fistula, which is what you're working on, the national goal is 66% or more, but now our medical review board this year increased our network goal to 8% because CMS set our goal at 67.3. So this sheet is a little outdated. The percent incident patients with AV fistulas is still 60% or more is the goal, and we will have our project working on incident patients. And then we also have a long-term catheter project going on, and the percent patients, prevalent patients with catheters greater than 90 days with no other access in place, the goal is less than 10%. Now, hopefully you all have heard of and seen the measures assessment tool, the MAP. This is a tool that was created for the state surveyors, and this is what they use when they come into your facility. And all their quality indicators that they're looking at are on this map. But this is the vascular access section. So the fistula is preferred access. The graft is acceptable if a fistula is not possible. And for central venous catheters, you should avoid using them unless it's a bridge to a fistula, a graft, or if they're going to be transitioning to peritoneal dialysis, or if they've got their transplant workup and they're going to be transplanted, if they have a live donor, for instance, or if they're a pediatric population and they're too small or they have too small veins. If you don't or have not seen the map, the most current version is on our network website, nwrenalnetwork.org. CFC stands for Conditions for Coverage, and it's the measures assessment tool. So let's take a look at the project goal and how the whole process is going to work. So we started and we looked at March data, and then you saw we looked at June data, and then we looked again at July data. So the information that we're using for this project was a result of the July data. Now remember, our reporting data, you report to me the following month that something is due, and the dashboard that's posted nationally is 2 months behind. So this is the most current data that we had at the time we were looking at the information. Because I know some people have called and said, well, gee, my September rates are really good. Well, we don't have September data yet, but we sent you out an environmental scan on issues that might prevent you from having more AV fistulas. That is due back into the office. You can fax that back as soon as you can. Today we're doing the WebEx kickoff, and then we have an educational WebEx set up. Now, you were told in your cover letter that you received which one of the educational WebExes that you're supposed to attend. So it's either going to be one on AVF maturity, one's going to be on converting grafts to fistulas if you have high numbers of grafts, and the other one, if you have high catheter numbers, then you're going to be in the decreasing long-term catheter education program. So that is on your cover sheet, and it's bolded. So you are allowed to attend any of the educational WebExes that we have coming up, and we've got a list of them at the end here. And when we're done with the program today, I will send you the slides for this project. Then you're going to be doing a monthly reporting on the AVF tool, and we'll explain how to go about completing that. And again, it'll be submitted on a monthly basis. And then in November, we're going to send out a query, and the query is not for you so much as it's for us, and that's to help us to design better projects for you to work on. So it's going to ask if this helps you to develop your action plan and set your goals for your facilities, and whether or not the education that we provided was helpful for you, and whether you got enough technical assistance for this project. The ultimate goal of the project is to raise the aggregate. So again, we're not going to look at individual facilities. We're going to look at you all as one huge facility, basically. We're going to take all of your data and put it together and look at the aggregate number, the AVF and use rate, at intervention facilities, and we want to try to raise that by 1.5 percentage points by March 2012. Now, that means because we're a month behind when you submit your data, it's going to be the February data. So this project will end at the end of February. You'll get your official data, and you will put that in, and you'll send me that sheet in March, and then you'll be done with the project. So it's going to run from now until March, mid-March. So what are the process steps that are involved? I know you probably died when you saw all of those attachments come through, but a lot of those attachments are just one-time things that you need to send to me. So we're going to take these pieces of paper one at a time, so try to decrease your stress level, because I know that was, it was pretty amazing when I was attaching them. So you need to do a root cause analysis. So the environmental scan that I sent you is going to help you to do that, because it's going to ask what you think your barriers are and identify issues. Now remember, when we do root cause analysis, we're not going to look at patient by patient by patient. What we're going to look at is what's going on in my clinic in the big picture. And for instance, they're going to be looking for patterns of problems. So we're not going to look at Susie's, inability to get her access to mature, but if you have 25 of your patients that are having problems with maturation, then we focus on a maturation process to try to improve that, so that as a group, we'll see a group of individuals, and your numbers will improve that way. So we have to think of the large picture here. So the environmental scan that you're going to send back to me will help. Also, a fishbone diagram. Those typically are pretty easy to utilize. And when I send you these slides, I'll send you the fishbone. You can use it if you want, but you don't have to send it back to me. That's only for your internal use only. And if you find that it's not as easy as I think it's easy to use, then you can use whatever tool. There's lots and lots of tools out there that you can utilize to do a root cause analysis. Then you'll have to submit an action plan, and the action plan has 2 pages. There's a Network QAPI document, and that one we'll go over in detail. We've got a picture of it, and we'll talk about that. And then there's the actual action plan itself. It's what are the steps that you're going to initiate in order to move the numbers in your facility, to increase your AVF in use rate. And then the monthly measurement tool, we have the AVF functionality tool. That is that Excel spreadsheet that I sent you. That needs to be filled out on the computer. I don't want it hand-filled out. It's designed, it has drop-down boxes, and it's supposed to make your life easier, not harder. But you will not send it to me electronically. You will print off the page, and only the number of pages that you have patients for, because it's like 60 pages long for lots and lots of facilities. So if you've only got a few patients on there, you'll go to print, and then you'll go to pages, and you'll put in how many pages you have, 1 to 2 or 1 to 3, and then you just print that many pages, and you will fax the documents to me. Because it will have patient-specific information, if you email it, you will be in violation of HIPAA. If that happens, obligated to tell my security person and have to tell CMS who has violated HIPAA. So please do not send anything via email to me. And then what you'll do is you'll look at this functionality tool, and if you notice that things aren't progressing, then you have to take a look at that, plus your action plan. You may have to change your action plan to meet that. But your network QAPI and your action plan are only submitted in time unless you make major revisions. So this is what a fishbone diagram looks like, and you can see there's categories at the top, and there's clauses under each category. So one category may be, patients. And, we've got patients that allow them to put fistulas in, but then don't allow us to cannulate. Or patients refuse because they don't want to have that ugly-looking thing on their arm. So that would be one category. Another category might be staff. So it might be that you've got cannulation problems in your facility. So you would list different causes that have to do regarding the staff. Then another category may be surgeon issues. So all the issues that you might see, with the surgeon. And then your problem would be that you have low AVF and use rate. So that's the effect. You've got all these causes, and it's causing this problem to occur. So then you focus on those categories, and you pick one of those categories that you will actually try to change. And then, and this is electronic, so you can actually go in there and click, and you can see that box is highlighted. You can name your own categories and put your own causes in. So this particular one that I'll email to you is very user-friendly. Now, for those of you on the fistulafirst.org website, there is a root cause analysis already done. Already have, you can see on the left-hand side, there are the categories, and then there's problems. And then there's some reasonable, the question is, can I change this problem? And you can see there's lots of yeses, and there's some no's on the right-hand side. So there may be some things that you can't change. Those are called exogenous factors that, we've got some walls and there's no breaking down that wall to be able to change this. For instance, if you are in a very rural community and there's 300 miles to the next surgeon, is it feasible for that patient to travel all that way, or can they? Do they have transportation to go 300 miles to see a better surgeon than the one that's in their town? So those are some of the things that might not be able to be changed, although we might try to think outside of the box and say if there's some money available somewhere that we might get to help that patient get to that town to get so you're more than welcome to take a look at that, because that might help you in your brainstorming process. So that's available on the Fistula First website for you. Or I can send you a copy of that if you'd like. Now let's take a look at the QI tracking tool, because this looks a little overwhelming. So you can see where there's red here, it says place facility name here. Again, I told you this is an electronic form, so you click on that box, you'll put your facility name in there. And then the person who's been assigned to be in charge of the project, you'll put your name there. And the provider number, that happens to be the 6-digit Medicare number that your facility has. If you're from Washington, for instance, it's a 502 or a 503 number. If you're from Alaska, it's a 022 number. Idaho, it's a 132, but it starts with 1. And Oregon, it's a 382 number. So put that number in there, and then once a month, your first reporting date will be 9/30. So that is the month that you're reporting for, is the month of September. That will be submitted to me in October, but keep the 9/30 date on it, but I know it's for the September data. And then put your phone number in here so I can call you if there's a problem. So that's how we complete the top portion of this. And then you do a file save as, and then every month all you have to do is go in and you change this date, and all of this is already there. And then if you need to change your patient name, then you can go in and change the patient name. Now, because this is so you'll put the patient name here, and then it has a drop-down box, whether they're transfer in, whether they're new to ESRD, whether they're returned from transplant. The people we want on this sheet is anybody who has a catheter in, whether it's a catheter only, or whether it's a catheter with a fistula maturing, or catheter with graft maturing. We want to be able to track how those accesses are doing, because we want to make sure that they end up being functional AVF and use accesses, all right? So you'll put in the date that their fistula was placed. You'll put in the surgeon name who created that. You'll put in the location, And like I said, these are drop-down boxes so that when you click in the box, a little arrow will come up here. You'll press on the arrow, and a list of positions will come up, and all you do is click on it. So it's really pretty quick to put patients in. Where the location of the access, this yellow column, whatever date you put here, it will automatically populate 6 weeks out, or 42 days. So that is the date, kind of like the target date. We're looking to see whether or not this access is ready to be able to be cannulated. And then this wants to know whether or not mapping has been done, vessel mapping. And then we want the actual date of first use, that you actually did it. And then we're going to look at this date versus this date. And if we see this date is getting further and further away from this date, then you're going to move over here and you're going to go into what you're going to do about the problem. Because obviously if you're not using it within the 6 weeks, then there's something that we have to address about that access. And then we want to know if the fistula is being utilized, yes or no, and whether or not the catheter is still there, yes or no. And so we're going to leave these people on here over the course of time. Because then that way I'll see if something, whether they've matured and they're using, because then we'll see a yes in this column and a no in this column. But if you notice that your date is getting further and further out, then there's a problem here, and there's a drop-down box of what is the problem with the patient. And then you've identified that problem, so now what are we doing? What intervention are we doing? So here this fistula was too torturous to use. And then there's another problem going on. Now they have an infection. So what was the primary intervention because it was too torturous? Well, they have a surgical revision scheduled. And a secondary intervention, they may have to have a fistulogram done. So there's all kinds of different topics to pick there. If you notice that there's something that's happening that there's not a thing in a drop-down box, when you go to print out, all of this will be populated. Leave this blank, and then you can handwrite right in the box what the problem is if there's not that problem in that box. And again, you just use a file save as. Now, let's take a look at what the conditions for coverage say about QAPI. If you've been through a survey since the conditions have come out and you've got a citation for this, you probably already know. But if you haven't, we're going to make sure, it's my job to help you get through state surveys so that you can stay open and running, because our patients need to have the dialysis treatment. So you can think of me as the helper person. The network has always been in that role of being a helper and providing assistance to you. So the conditions say the dialysis facility must develop, implement, maintain, and evaluate an effective data-driven QAPI program with participation of the members of the interdisciplinary team. Well, who is the interdisciplinary team? It's the doctor, the surgeon, the nurses, could be the nurse manager, the facility administrator, clinicians, and above all, it's the patient and or their designee, because they have to be part of the process. It's all about them. And it also says that your QAPI must focus on indicators related to improved health outcomes and the prevention and reduction of medical errors. So our focus is on the improved health outcomes, pretty much. And so this is what the map says that we should be focusing on. So for cuffed catheters greater than 90 days, so those are our long-term catheters, you're going to be working on decreasing those numbers to less than 10% of your population. AV fistulas for dialysis using 2 needles, that's the definition of a mature fistula. It's using 2 needles at the ordered blood pump speed without infiltration. And you are to, according to Kdoki said to increase your AV fistula rate to greater than or equal to 65%, and the fistula first CMS goal was to get greater than or equal to 66%. Remember, that's the national goal, but we have a unique goal of 67.3%. And so you're also supposed to monitor your clotting episodes and have them to less than 0.25 per patient per year for fistulas and 0.50 per patient per year for grafts. Your infections, you now have gotten on your dialysis facility reports for the first time your vascular access infections because they started collecting that data in July of 2010. And you're to keep those infections less than 1% for fistulas, less than 10% for grafts. And then, of course, we need to keep them patent. And so the goal here is to increase fistulas, the percent of patients with fistulas that have their accesses longer than 3 years. So we want to keep those accesses, we have to maintain them, is what they're saying. And then grafts, we want to make sure that the life of the graft is at least greater than 2 years. Again, there's the link that takes you to the map on the website. Now let's take a look at the forms that you need to complete. The Network 16 QAPI form, you'll put your facility name at the top and that 6-digit Medicare number and put the date. And then you're going to look at what your percentage is now. And what you need to do is you need to determine what a reasonable goal is for you. For instance, if you have 39% AV in use rates right now, you're not going to get to 67.3 in 6 months unless a miracle happens. And so you have to make a realistic goal. So, for instance, you might, if you're at 39%, you might try set your goal at 45%. Because the conditions for coverage say you have to work towards network goals. It doesn't say you have to achieve those goals, but you have to work towards those goals. You know, because our goal is 68%, even though our official first goal is 67.3. So set a not too easy a goal, like, oh, I'll put it for a 0.5% above what I am now. No, you have to work one that's going to challenge you to increase those numbers. And then you're going to make a statement. So your opportunity for improvement will be that you will improve your ADF in use rates from this percent to this percent. So, and then your current situation, what's your current AV fistula rate? And we're going to do, so you'll put that in for September. So what is your September rate now? And then the problem identification, it says list at least one problem that your facility has identified to attain or maintain or exceed that performance target. So what's one area that you find that you're having an issue with? And then what activities are you already doing? Because you're probably already doing something to try to improve those numbers. And we don't want you to reinvent the wheel. If you already have a QAPI in place for improving your fistula rate, all you have to do is transfer it right over to this form and send it in. If you want to send me what tools you're using, that's great too. Some people do that. If they've already got a plan, they send me their whole packet. And so I have that and I look at that. And I keep that here in the office. If you're using a protocol, do you perform chart audits? That's yes or no. It's okay if you do, it's okay if you don't. So it's not like, oh, if you say no, I'm going to make you do this. No. I just want to know if you're doing it and how often, if you are. And, but if you're not doing audits, how do you know for certain that things are being followed? If nobody's looking at the chart, how do you know that people are following your policies and procedures in your unit? Do you do periodic checks? Do you do an annual something or other? Do you do a chart review of 5% of your patient's run sheet in a month to see? That's how we make sure that things are being followed, and if they're not, then that's how you get, you have to do something about it to change that. So that if the audit shows that protocols are being followed, but you're still not reaching the, then what is it that you plan to do about that? It may be that you picked the wrong thing to focus on. And if you're not seeing a change in your numbers, then you obviously haven't picked the right thing. to move those numbers. So, and if you get stuck like that, you can give me a call, and I'll be glad to troubleshoot that with you. Now, on the action plan itself, what you're going to do for the upper part there is you're going to take what you did on the Network 16 form, and you're just going to transfer that information over. Already done it, so you don't have to try to think of something different. We want you to put what's on that QAPI form on your action plan there. And then what we do need you to do then, now that you've identified what your root causes are, what your barriers are, what actions you're already taking, now what new steps are you going to take? Or if you're in process already, you put what you've been doing, and we want to identify who's in charge, because if nobody's in charge, it might not get done. That's why we asked you to identify a lead for this project, because that person does not have to do this whole project, but they have to direct this project. So get some technicians to help, get some nurses to help. You can get your admin staff to help you. You don't have to do it all by yourself, but you have to be the responsible one that's going to make sure that I get the forms that I need and that I get my monthly reports on time so that I don't have to be chasing you. Do not save it to the end of 6 months and then submit everything, because I know you're probably not doing anything for this project. So you'll put your action plan, what your steps are. For instance, if it involves doing some kind of education, then you're going to put that. You can actually put that you'll be attending an educational WebEx in a couple weeks, and that I'm going to be doing that, and you'll put that date, and then when it gets completed, then you'll put it in the complete date, and you can say how many staff attended, or that was completed, that so-and-so attended, under the comments section. So we've got the responsible person now. We've got a start date of when we're going to actually start this whatever step. Then the estimated completion date. How long do you think it's going to take realistically? If you think that tomorrow you're going to educate the entire staff, I don't think that's a very reasonable assumption for you to make, because we know that we might have call-offs tonight, in which case everybody's on the floor working and nobody's available to do education with. So, and it might be that you have to do it in little groups instead of in one big group. So if that's the case, it might take you a week or a week and a half to get it done. So be realistic about how long you think it's going to take. But remember, we're doing rapid cycle improvement here. We're doing an improvement project that lasts only 6 months. So the things that you put on your action plan, we've got to get to within that 6-month period. So think about those kinds of steps that we're going to be using. And then the checkpoint date. Before you get to that final date where you thought you were going to be done in a week, check in midweek and see, am I there? How many staff have I actually reached? Or how many patients have I talked about? Have I had a conversation with my medical director, if that's one of your steps? Has your medical director talked with the surgeon? If that's one of your steps, have they done that? Check in and follow up and see. And don't wait for the completion date and then find out, oh gosh, we haven't even had a chance to look at that. That's what checkpoint dates are all about. And then your actual date of your completion goes right there. And then you just keep track of that. And if I see by your numbers that you're not improving, or I'm looking at your tracking tool and you're not improving, I may ask to see how you're going on your action plan and how your steps are, because you're going to send me the original plan. And again, I don't need to see it again unless I think you're not moving forward. So you don't have to send this to me month after month after month. Only unless you add new steps or make complete changes in what you're doing do I need to see it again. So these two forms come to me before mid-October, and I don't need to see them again, unless I call you and ask you for them. So this project that you're doing is going to be incorporated into your QAPI process, and somebody needs to be reporting this out in your QI meetings. So because this is only 6 months long, hopefully you're having monthly QI meetings. You don't discuss everything on a monthly basis. Some things you may discuss quarterly, but this project you may discuss on a monthly basis to make sure you're moving. And then you have to document that progress in your QI minutes. So, for instance, you're going to have a report. We attended this kickoff meeting today. We completed our action plan. We submitted that. We've started on steps 1 and 2 here, and we've completed step 1. We will be, by the next meeting, our focus is to have this step done. So, and that needs to be in your minutes, because when the surveyors come in and they know you're in a project, they will ask to see documentation that you're doing it, and the documentation comes in your QI minutes. All right. And let me just tell you a thing. We've created a document for the state survey agencies. They send us a list of facilities that are going to be surveyed. And we don't know the date you're going to be surveyed. They don't tell us that. And we're not permitted to tell you, so don't bother. Even ask. But we will complete this form, and there's a section on, has this facility had any complaints and grievances? And if so, Lisa fills that out and lets them know. For data, is your data form submitted on time? Do you have to be nudged? Or do we really have to beat you over the head to get your forms in and threaten you? There's a section for that, and then there's a QI section. That QI section asks what are the goals for fistulas and catheters, and what is the facility's rate. And so I put those in there based on the most current fistula data I have. Then it asks if you are in any QI projects, and I list those QI projects. And then it asks if you're turning in your forms on time for me as well, or whether I have to contact you, or whether I have to go any further than that. And then we fax this form back to those surveyors so that they have it when they walk into your unit. So that's how they know you're in a QI project, is because we told them that. So they might purposely look for that. So as you make these documents, everything's electronic, but you might want to create a folder, because you're going to have to send me monthly reports anyways. And so having it in a folder that you could hand to them so that they can see your process and your progress will keep you out of hot water with the state survey agency. So how can the network help facilities? Well, I look at all your action plans that come in. And if there's a question about it, then I call you back and say, I don't quite understand this, or this isn't kind of a measurable thing that you can really say that this is going to cause a change. I review that monthly tracking document that comes in, and if I notice that dates aren't matching and I don't see any interventions going on, then I will probably give you a call. I can help you if you have to revise your 2 API. If you're not moving forward, please utilize me. That's what I'm here for, is to help you with this. And then remember, in November, we'll be sending out that impact assessment. It's just a 1-page questionnaire about how we're doing for you. And then you fax that back to me. And then we actually write up this report, and we send that report to CMS to tell them how well we're doing with our projects and how well we're meeting your needs. So that's for our grading. We get graded on an annual basis from CMS. They come in, they go through all of my records. They challenge all my projects. They want justification of why we did it the way we did it, and we have to do that. And we have to provide that information to them on an annual basis. And they come in April, so that's why we need all of your stuff by March, and we need you to be on time because they show up in April. And we have to have all of our final reports done. We have to have all those interim reports done. All of those scans that we ask you to fill out, we do progress reports on that, and CMS sees all of that information. We don't just stick it in the drawer and say, there, it's done. We actually utilize that information that we have to try to help change practice in our network. Then the remeasure period is March 2012, which is the February 2012 data. So that, again, is the end of our project. Then we provide technical assistance throughout this entire project. So what is that? Well, depending on what your problem is, and you all have some different problems. And so that's why you individualize it for your facilities. But for long-term catheters, the Forum of ESRD Networks. That group of individuals, they kind of oversee the networks, and they provide assistance to us if we need it. They have developed a catheter toolkit, and it's called the MAP toolkit, and you can download that, and it has usable forms for you. So if you're trying to reduce those catheters, great resource. Great resource. You have high graft rates. There's presentations. We're going to talk about the 3-step protocol. There's checklists available for you, and that's what we'll be talking about in our educational program. If we've got some physician, you know, if you've identified some physician issues, we've got some resources from Fistula First. We've got surgical DVDs that we can give out to the surgeons. When they first came out, we sent them out to all the surgeons. If you've got new surgeons in your area, since 2008, I think, we'd be happy to send them. Got a lot of them here. We've got the cannulation videos. If you misplaced yours or it never seemed to materialize, one was sent to each dialysis unit. If you're a new facility and we missed you, you can send me an email and I'd be happy to send that to you. You all got the Vascular Access Atlas in the mail. That was a DVD that was given to you from the network. It was in your Vascular Access Toolkit. And then we have access to peer-reviewed literature, so if there's some, you know, we do this because it's the way we've always done it. That doesn't fly anymore. We really have to follow evidence-based research and evidence-based practice, and we have that literature available for you. So if you need something on a particular topic, please send me an email, and I'll be glad to send you that literature that you can share with physicians, surgeons, nurses, techs. And then AV fistula, failure to mature, there's lots of data out there now. There's lots of publications and presentations. And again, we'll have our education presentation on that subject as well. So these are, we're doing 5 different education programs this year. And you, again, you're entitled to attend any one that you want, but there's one that you're mandated to watch, and that, again, was on your letter that we sent you. So on Friday, October the 7th, from 8 to 9 Pacific time, we have strategies to increase incident patient AVF and place rates. So we do have a project going on with that, but you're more than welcome to attend because this may help you with your AVF and use rates if you get your new patients coming in to have fistulas already placed. Also on the 7th of October from 1 to 2 Pacific time, understanding and applying QAPI in everyday practice. So we have another project that's going on that's focusing on multiple opportunities for improvement. On Thursday, October the 13th, we're running all the ones that the required ones are all on October the 13th. So it's a long day for me, but you only have to attend one of these from 9 to 10 Pacific, assessing AVF fistula maturity, from 11 to 12 Pacific time, creating secondary fistulas from forearm grafts, and from 1 to 2 on the 13th, it's reducing long-term catheters. So, and you should have already received your invitation to register for the one that you're supposed to attend. If you want to attend those other ones, please send me an email so I can send you the paperwork for that. So I want to thank you all for attending, and now we're going to talk about what the next steps are going to be. So your next steps, you're going to complete that root cause analysis and get that faxed back to the network office. Remember, your action plan and your Network 16 QAPI form is due into the office by October the 15th. So you've got a couple weeks to work on that. Get your QI team together. You need to submit your first monthly AVF functionality tool in October or September. So you have to wait till the end of September, just like you do for your Fistula First report. We need to have the month completed before you start filling out your form. And then please call me for any questions or issues. There's my phone number, extension 111, and there's my email address. And then there's going to be a short survey that's going to pop up on the screen. And if you'll take that before you hang up. And we're going to go to questions now. So we're going to, if you want to ask a question, you can unmute your phone by using *6. Again, please don't identify yourself or your facility, and just ask your question.
And then, did you say you were going to send these slides to us via email?
I am. I'm going to send you that and the fishbone diagram as soon as we're done with the call.
Great, thank you. And then you asked, or you mentioned about the root cause analysis. When did we get that one? I don't see it.
It was in one of the 8 attachments. It was one of the 8 attachments you had on email number 1 of 2.
Okay, I'll have to look for it.
Also, when you're looking at those attachments, because there's so many attachments, there is a little scroll bar on the right-hand side. You'll have to go down so that you'll find all of the attachments. I'm assuming if you found the one to attend here that you found them all, because these are the last 2, the education presentation. You can see the poll is up. If you would please take a minute. This is anonymous. I don't know who fills out the poll. I just get basic numbers. I get answers. You know, they tell me how many people answered this way. So I don't know who in particular answers the poll. Just please take your time to answer the poll for me.
Linda?
Yes.
I just wanted to ask, on your monthly tracking ABS, the per patient one, that you want ABS they have a catheter or early in use, so new maturing ABS, and then catheter patients. Do you also want all ABS patients on there?
If you're using that fistula, I don't want them on that form. I want maturing fistulas.
Okay, and catheter patients if they're in the process of getting vessel mapping and all that, right?
Yes.
Okay, thank you.
You're welcome.
Linda, on that same form, you had said if we email these forms to you, it couldn't have the patient's name on them. But this form, I understood you to say we needed to email to you, and it has patients' names on it.
No, nothing gets emailed to me. Everything gets faxed.
So this form we print out after completing it and fax.
You do. You fax it.
All right.
Remember, only print the number of pages that you have patients' names for. Otherwise, you'll get 60 pages.
Just to clarify again, so the ones with the patient's name, you only would like data with fistula and catheters, not with grafts, right?
Right. I think I might have said grafts before, but no. It's only with fistulas maturing.
Okay, fistula maturing with...
So, if they have a graft with fistula maturing, if they have a catheter with fistula maturing, then we want them on this form.
So you just said also with grafts maturing.
Grafts with fistulas maturing.
Oh, sorry, gotcha. Graft with fistula maturing.
Those are the categories that we have that have maturing fistulas. There's graft with fistula maturing, catheter with fistula maturing, or a catheter with no other access.
Okay, catheter with a plan for permanent access, you mean?
Yes.
But we wouldn't know whether the doctor would place a graft or a fistula, though.
Excuse me?
But we would not know whether the doctor would want to put a fistula or a graft, though.
If they put the fistula in and it's maturing, if they put in a graft, then that information won't go on this chart. It's just that they choose to put in the fistula.
Okay, so I just want to clarify again. If they have a catheter, but no fistula yet or no graft, but there is a plan on the way, we don't put them on the report?
I think what she's asking is if you have a patient who has only a catheter, and we're going to put them on this form, right? If they just have a catheter, but a plan in place to get a fistula or a graft, do they go on this form? Catheter only.
The catheter only, if they decide that they're going to put a graft in there, they'll have that patient's name on there, and what you'll do is when you print it out, you won't have anything listed for the graft date or for the placement date. You can just put right across there, patient had graft.
Okay.
And then we won't track that person anymore, but at least we know what happened to that catheter, that it turned into a graft instead of into a fistula.
And they stay on the form, correct?
Yes.
So they stay on the form until we finally figure out whether it's getting a graft or a fistula, right?
Well, you leave that on there, and if they get a graft, just put graft on there, and then you won't have to do anything with that patient anymore. You don't have to do anything at all with that. Unless that graft fails and they do put a fistula in that case, then we would change all that information.
All right, thank you.
When those individual questions like that come up in your facility, you can give me a call and I can walk you through the form. It's really kind of hard because you haven't started using the form yet. So until you start to use the form, you might have some questions.
What do you do if you have a person that has a catheter and they have no AVF possible? Do you put them on there?
I would, and then just put a note there that over on the far end there, where you don't use any of the drop-down boxes or anything, but when you print it off, just write in there that the patient is not a candidate for fistula, and then that way you won't have to do anything with that patient. Okay, thank you.
I have one more question. The unit action plan that we're doing, you just want the initial one that we do here in early October, and you don't want it anymore unless we make drastic changes to it. So even if we make additions, like we decide we want to add another action based on what we're finding, you don't want that copy as well. You just want the initial one.
Well, if the major focus is now going to shift to that new step that you added, then just fax that to me.
Okay.
All right. Well, I want to thank you for attending. Hopefully you filled out the poll. So this will conclude this session, and I will see you in the next educational session. Thank you so much for attending today. And remember, if you have multiple people at your site, send me an email and tell me who the other people were that were attending with you on the phone. Thanks a lot. Bye-bye.